Good evening, everyone, and welcome to the second of 6 lectures in our DocTalks lecture series. My name is Karen Perkin. I'm the Vice President, Patient Care and Chief Nurse Executive here at St. Joseph's Healthcare London. And it is my pleasure to welcome all of you here this evening. Now, I know I'm biased, but I do know that there's some truly exciting innovations happening within these very walls. I have the pleasure of working with some of the best and the brightest in the country to help improve the quality of care for those we serve. Dr. John Denstedt is one of these impressive people. He is a graduate of the Schulich School of Medicine and Dentistry at Western University, and he completed his residency in urology here in London. In 2002, he became the citywide chair-in-chief of surgery in the Department of Surgery at Western University, and he held that role for 14 years. Dr. Denstedt is the past chair of the Canadian Association of Surgical Chairs and the first Canadian to be named Secretary-elect of the American Urological Association, or AUA, during its 118-year history. He will begin serving a 4-year term as the Secretary of the AUA in May of this year. In addition to maintaining an active clinical practice, Dr. Denstedt is internationally renowned scholar in the field of urology, publishing more than 250 papers and book chapters. He's completed more than 200 guest professorships in countries throughout the world, and he has received numerous honors and awards, including being the first Canadian to have won the Gold Cystoscope Award from the American Urological Association in 1998. Tonight, he will discuss a topic that 1 in 10 people will have experienced in their lifetime: kidney stones. And if any of you have ever had kidney stones, I know you'll attest to how excruciating that pain is. Dr. Denstedt will talk about treatments for kidney stones that have evolved over time, including current prevention strategies and how new research is unlocking new possibilities for the future. Please join me in welcoming Dr. John Denstedt.
Well, thank you very much, Karen, for that very kind introduction. I greatly appreciate it, and thank all of you for coming out here. It's March break week after all, so you've stayed here in Canada and decided to come out for my talk, so I greatly appreciate that. Can you all hear me okay? If I sound a little bit raspy, I've got a little bit of a cold, so I just want to be sure I project for you okay here. So we will talk about kidney stones. I'm going to talk a bit about the surgery for stones, how to prevent stones, and I'm going to weave into that talk a few life stories as well. Karen has referred to a few things there in the introduction, some experiences I've had, so I'm going to weave that into the talk as well. So just to start out here then, how common are kidney stones? So a little more common in men than women. About 10% of men will get a kidney stone. And very interestingly enough, the highest incidence of stones in North America is in the southwest of the US, so the Carolinas, Georgia, and so forth, and right here in southwest Ontario. We don't know actually why that is down in the southern states. It's probably the heat, the dehydration, and so forth. The heat for 6 months of the year is not a big problem here, so we're really not sure. People have attributed it to the water in this neck of the woods, but we're really not sure quite why it's so high here. The peak age is about 30 to 50. If you've had one kidney stone, your chance of getting another one is at least 50% in your lifetime. Pretty rare in children, but it can happen, and we'll talk a little bit about that. So the incidence is going up very dramatically. In fact, over about the last 20 years or so, it's doubled here in North America. And why is that? Why is it going up so quickly? It's probably a combination of things, bad diet, obesity, diabetes, things like that are leading to more and more kidney stones. The cost of looking after all of this, you're going to see here in a minute, there's a lot of technology involved in it. It's about $10 billion a year in the US. So in my specialty of urology, the cost of looking after kidney stones outweighs everything else that we look after, including things like prostate cancer, bladder cancer, and so forth. So it's a very expensive problem. So with all those people getting kidney stones, of course, there's a few famous people that have kidney stones. And we can maybe get a bit of interaction going on here. Do you recognize any of these folks? So we've got Gene Simmons, from the KISS rock group. John McCain had a kidney stone. Lionel Messi, soccer star. Alfred Hitchcock. Who's this guy here? Bezos, richest man in the world, owner of Amazon. He's had a kidney stone. 3 or 4 U.S. presidents have had kidney stones. Lyndon Johnson, Ben Franklin. We're still waiting for Trump to get his kidney stone. As far as we know, he's not had a kidney stone quite yet. Billy Joel has had a kidney stone. And all of this is public knowledge, by the way. I'm not putting anything out there that's not widely known. And interestingly, William Shatner has had a kidney stone. He was the speaker, I think, at our foundation event a couple of years ago. The interesting thing about Shatner is, and you can look this up, he actually sold his kidney stone on eBay. And he made $10,000 off of his kidney stone, and he gave the money to charity, actually, from selling his kidney stone. Phil Jackson got his stone during March Madness, right at this time of year, famous basketball coach. So a lot of notable people have had stones. So how does it present? And I think everybody's pretty well aware of this. It's terrible pain. Excruciating pain starts in the back, radiates around the front. Women who, of course, get kidney stones too and have had childbirth and delivery will tell us the kidney stone is much, much worse than that. So most people will say it's the worst pain that a human being can experience. There can also be blood in the urine, urinary infections, and so forth. So, a stabbing pain in the back is the typical symptom. For those who used to watch Seinfeld by any chance on TV, so Kramer had a kidney stone. You might remember that from an episode. And he was standing in a washroom, urinating, screaming in pain. But that was actually factually incorrect. So the pain of kidney stones is getting the stone from the kidney to the bladder. Once the stone's in the bladder, people, if I can say, will pee out the stone and usually never actually feel it come out. So they portrayed Kramer a little bit incorrectly in the Seinfeld episode. So of course we make the diagnosis with x-rays. This is a stone here, about 1 centimeter or so long in the right ureter, typical kidney stone. So we'll talk now a bit about the history. So when every medical student graduates from medical school, it's a very, sort of hallowed event graduating med school. And we all sign the Hippocratic Oath that day on the spot when we graduate from medical school. And there's various iterations out there of the Hippocratic Oath. Hippocrates was a physician back in the time of the Greeks, but in almost all variations of the Hippocratic Oath, it says, "Thou shalt not use the knife for patients with kidney stones." So this goes back to the time of the ancient Greeks. And we think why Hippocrates wrote that down, why you shouldn't use a knife on a patient with a kidney stone, is because of this. So this is the operation, back whenever 2,000-3,000 years ago. This is the patient here. He's being held down by the anesthetist. Of course, there is no anesthetic. And the way the operation worked with instruments something like this was, an incision up through what we call the perineum directly into the bladder, and then you pull the stone out of the bladder. So the reported mortality rate, the chance of dying with this operation, was about 50%. And if you did happen to survive, what we call the morbidity or the trouble, after surgery was the other 50%. So things did not go very well with that operation. So, for 2,000-3,000 years, that was the state of surgery. Then at the turn of the last century, we entered the era of modern open surgery. And this is what we did even back in the day when I trained, and this will be the only blood and guts photo I'll show you. This is a kidney open here. We're taking a kidney stone out of the kidney, and this involved a big incision in the flank area. People were in the hospital a week, took 6 weeks to recover. 50% chance of another. You'd be back in there, a few years later, and eventually the kidney would be lost from repeated surgery. So not very good. So about 30 to 40 years ago, we entered a new era of treating kidney stones with three essential things that appeared almost at the same time: percutaneous surgery, ureteroscopy, and shockwave lithotripsy, and we'll talk about those three techniques. You'll just note the bottom line here, which we'll talk about a bit more as well. So percutaneous surgery is something like most operations now we do through very small holes. People call it keyhole surgery. In this case, we go in through the back, through a very small incision in the back. But if you go back, even in the 1940s, there's evidence of percutaneous surgery, and very creative people, urologists happen to be very creative folks with instrumentation and so forth. So this guy, Tratner in Cleveland, he developed a whole bunch of scopes at that time, endoscopes for doing these kind of manipulations in the kidney, even back in the 1940s, and just some examples of the instruments. Nobody quite knows what he was thinking about with this. This is well before the era of AIDS and transmission and stuff like that. But anyway, something was on his mind. He was worried about something, and that was his operating. We don't use that anymore, and it's not part of the armamentarium, we would say. So modern percutaneous surgery began in the 70s in Sweden. I went to the University of Minnesota. This was all happening when I was training here at St. Joe's. And the rest, as they say, is history, and there's been a whole lot of other innovations for this particular operation. And what we do with this surgery, it's for big kidney stones. So it's the very small stones that cause the severe pain, a very sudden presentation, and people in the emergency, and in this city today, there'll be at least 8 or 10 people in the ER with an acute colic. Most of those stones will pass on their own and not need anything done with them. But stones can be as big as what we see here. We call this a staghorn stone. It's as big as my fist, and these are the types of stones we take out with percutaneous surgery. So we have one of the largest experiences in the world in doing this operation. It's probably us, a good friend of mine in Indianapolis, and another colleague in India. And through that small hole in the back, we can achieve over 90% stone-free rates, take that huge stone out in a couple of hours in the OR. Patients typically go home the next day after that surgery. So a huge revolution in the way we treat them. Of course, modern imaging helps us out to plan the surgery. This is a 3D reconstruction of stones in the kidney. We get this before the surgery to properly plan things out. And if this will play here, so this is actually inside the kidney, looking in through that little hole in the back. This is a ultrasound probe, and you can see it breaking up the stone and suctioning it out of the kidney at the same time that we're operating. And then afterwards, we leave a little tube in the back, take that out the next day, and home the patient goes. So it's a massive change in the way that we treat kidney stones. So 20, 30 years ago, this would be a big incision, potentially lose the kidney, so a great advance. And all of this is accompanied by very interesting technology. So this piece of equipment comes out of the Jet Propulsion Laboratory in Pasadena, California, and out of the Mars rover that's still up there roaming around on Mars. So NASA needed a way to break up the rocks on Mars. They developed a ultrasound unit, comes out of the rover, breaks up the rocks on Mars, brings them in, sends the data back to Earth. This piece of equipment came from that. So it's essentially developed out of space technology and is something that we use in the operating room. So things have continued to advance. This fellow Desai in India, he's a very good friend of mine. He's now got this down. The typical sheath that we would work through in the kidney is 1 centimeter, small hole in the back. He can now do it through something like this, so a very tiny opening in the kidney, and those patients go home same day. I mentioned stones are rare in children, and indeed they are, but occasionally it happens, and when it does happen, obviously the anatomy is very much smaller, so we're called upon to treat stones in children, but you can do the same thing even in children this small. This was a 6-month-old child operated at Vic, with a kidney stone, and went very well, minimally invasive and so forth, and the child did quite well. So Karen referred, some of my opportunities I've had over the years, and there's been many of them. This happened to be in the country of Romania after the fall of communism. So the AUA, American Urology, decided to go into Eastern Europe and bring up the skills over there to what we're used to here. So I was one of the people, went over there, did the first percutaneous surgery ever done in the country, trained this individual here, who's still a good friend, in a hospital in Bucharest, Romania, took equipment from here at St. Joe's, actually bundled it up, took it over there and did the first type of that surgery in that country. And fascinating enough, and some of you might have seen this story in the hospital magazine, I said this whole thing started 30 or 40 years ago. Last year, I was in Haiti, down, hour and a half flight from Miami, and did the first percutaneous surgery ever done in the country a year and a half ago. So they're 30, 40 years behind. It's still all open surgery, very difficult conditions, but had a chance to train these docs. They're obviously very happy. A little bit of blood down there, but don't worry, everything turned out just great, and that was the first case ever done in the country. And then you look carefully, there's my little face right there, big group of Chinese docs. So I've been over to China, probably 40, 50 occasions in the last few years, training large groups of physicians over in China with these techniques that we've helped to pioneer right here. We're employing another technology now. I often, as I've indicated, will operate when I go to these places. There's certain risks associated with that people don't speak English, you don't have your instruments and so forth, but usually all has gone well. But this technology facilitates a much safer thing. So what it is a simultaneous video broadcast. This guy's in Chengdu, China. It's in the southwest of China. And we'll do broadcasts from here at St. Joe's over to China to the trainees over there with less than 500 milliseconds of delay in the video transmission, and broadcast the surgery and teach the docs over in China. Who has seen this movie? Just about everybody. So Top Gun. Top Gun is actually a real place. It's known as Miramar. It's a U.S. Air Force base just outside of San Diego. And I had an opportunity to visit Miramar during one of my meetings that was there in San Diego a few years ago. This young lady, this is her machine, and behind she flies a F-18 fighter. And she's one of only 2 or 3% of all Top Gun pilots who are women, but she's actually a Top Gun pilot. And I've always had a great interest in simulation for training during surgery. It's a means by which now we can train people, not on live patients, but in simulation models. We know they're using a lot of simulation in the aircraft industry, hopefully on the 737s as well from Boeing. And she was able to relate to me, all of the time she spent training to fly in an F-18 with simulation. So the main simulator for this kidney stone surgery that I've talked about was developed here. It's a company out of Israel that we worked with. These young kids, I will call them, moved here to London. They come to the OR with me every day, take videos, watch the procedure, learn about it, send the data over to Tel Aviv, Israel, and the next day they would have the next version of the simulator. So there's now hundreds of these all over the world. We've actually got the latest version here at St. Joe's. I think it was bought by the foundation, actually, for training our trainees here in London. So if we transition away now from surgery and percutaneous surgery, the other of the 3 developments I talked about was shockwave lithotripsy, and we'll talk a bit about shockwave here. So this fellow, Christian Chaussee, was actually a resident at the time, so a trainee in urology in Munich, Germany. And I come to know him quite well. He's still alive and well over there in Munich. And he was at a cocktail party where engineers, aerospace engineers from the Dornier Aerospace company those interested in World War II history would recognize the name Dornier. They used to make bombers for the Germans during the Second World War, Dornier aircraft. So Dornier is still around in military equipment. They're involved in explosions and so forth. So Chaucy's at the cocktail party, and he starts talking to the engineers about explosions and so forth, and they come up with shockwave lithotripsy. That's actually how it happened. The other interesting thing about Chaucy is he spent a year here in London, Ontario. So he was a trainee at the time. He became interested in transplants, and he was actually up at the University Hospital. But he had kept up the contacts with the Dornier folks back in Munich. He decided to go back to Munich and invented the shockwave machine. And he's always told me if he had stayed here, it would have been developed here in this city, actually, the shockwave device. So this is the initial machine that he came up with. Used to go in a tank of water. Shock waves would be generated in that tank of water, travel through the human body, and break up the kidney stone. That's the basic principle behind this. And the very first human ever treated on the shockwave machine was actually Christian Chaucy. So he treated some rats in an experimental way, then put stones in dogs, treated the dogs, and thought it was safe, climbed in that tub of water, and treated his own kidney. Survived the experience, and the rest is history. So all of the machines now are without the water tub. They look like this. And this is the latest version in Ontario. There's only 3 of these machines. There's one here, one at St. Mike's in Toronto, and one over in Ottawa. And for many years, the 2 busiest lithotripters in the world were the one in Toronto and the one here at St. Joe's. At one time, we're going to see here this technology has declined a little bit in its use. At one time, there was 400 or 500 lithotripters in the US, and at the same time, 12 of them here in Canada because of centralization of high technology like this. So for many, many years, people from all over Ontario would come here, 2,500 people a year for lithotripsy. So when Chaucy first came out with this, there was a whole list of reasons not to do it. These days, there's only one thing left. If you're pregnant, you can't have lithotripsy because of the effects of the shock waves. We use x-rays to target the stone, so we can't treat pregnant patients. But otherwise, just about anybody could be a candidate for this. But here's what's happening here in Ontario. We'll just take a minute and look at this. This is 1991 up until about 7-8 years ago, and this trend has continued. The blue line is the number of shockwave cases done in Ontario. The red line is ureteroscopy, that we're going to talk about, an alternative technique to treat stones. And the previous thing I talked about, percutaneous surgeries, about 10-15% of cases, and has been pretty flat throughout all that period. So this same thing is happening really all over the world. People have become aware of the limitations of the shockwave machine. Quite often people don't get rid of the stones after you break them up, so it's sort of declined in use throughout the world. And I've said people will hold on to the small particles of the stone after the shockwave treatment. There's been efforts to use percussion things, turn people upside down and so forth, so they'll flush the stones out, but most of the evidence shows that doesn't work. But here was an interesting thing, published actually in the medical literature, that if you go on a roller coaster and you're turning up and sideways and down and so forth, you will actually pass your kidney stones, and 60% of people will pass their kidney stone after going on a roller coaster. So, maybe we won't entirely give up on the shockwave machine, but it's not really a growth industry, we would say. A little more scientific than the roller coaster is this technology. Some pretty good friends of mine out in Seattle, University of Washington, have come up with a variation of ultrasound. So this is totally externally in the body, and it can actually pick up and move a kidney stone. Almost the same ultrasound is done in pregnant women, so there's no effects on tissue or anything, and move a kidney stone into a better location to treat on the lithotripter. So this is just in the phase of commercialization right now. It'll be interesting to see how it all works out. So we'll transition here now and talk about the last sort of technology and technique we use, and that's ureteroscopy. So the important thing with that to know, and the good news, is that 80 to 90% of small kidney stones will pass on their own. So people will drop a stone, they'll have pain, come into the ER, and if it's a small stone, certainly smaller than 5 millimeters, we'll usually wait it out for a period of time. And usually the pain improves and they're not in severe pain, and we'll hope that they pass the kidney stone. But for those small stones that don't pass, then we will do a procedure called ureteroscopy. And with this, and I won't go through all this technical detail here, we'll often present both shockwave and ureteroscopy to the patient. We'll go through these pros and cons. Ureteroscopy, you're actually sticking something in the person. You're looking up there with the scope. So it's not all external like the shockwave machine, but it's a much more effective form of treatment. It's a highly technology-dependent thing. So, these endoscopes we have, and this is the type of scope we used back when I did my training, and these things have become vastly miniaturized now. They are about 2 millimeters in size, the small scope. The ureter is a very small tube, but this small scope that's about 2 millimeters in size, we can easily get up the ureter and visualize the stone and actually treat it under direct vision. The most recent iteration, the trouble with that equipment is it breaks very easily. So you might get 2 or 3 20 cases or so out of it, and then the scope will break, and this is about a $20,000 piece of equipment, goes out for repairs. That's $10,000 to fix it. So now some of the medical device companies have built disposable ureteroscopes, which is incredible engineering. You use the thing once, you throw it away. We could certainly question the carbon footprint of all of that and the impact on the environment and so forth, but suffice it to say it's incredible technology. This is the throwaway scope, the view that we get compared to the standard $20,000 capital equipment that we buy and use for these treatments. The other thing, and I mentioned this in an earlier slide, was the development of the holmium YAG laser. So the first human being in the world treated with the holmium laser and has propelled that whole curve, that red line of ureteroscopy, all over the world. The first patient was treated here at St. Joe's back in 1993. I was brought this instrument by a person in the medical device industry. He said, "John, the orthopedic surgeons are cutting through bone, cutting through cartilage. Maybe it would break up a kidney stone." I said, "Let's give it a try, bring it in." Back in that era, remarkably, there was no approval process, there was no human ethics or anything else. We brought it in, and I still recall to this day the nurses in the OR saying, "What should we set it on, the laser?" And I said, nobody's ever used this before to treat a kidney stone. Put it in the middle, right, in the middle of the settings on the laser. And remarkably, here in 2019, it's the same settings that are used as put it in the middle. So we treated the first 23 cases, published it, and there's thousands of these things now around the world. That first laser here, just a side story, was actually bought, you might remember over on Grosvenor Street, the little volunteer shop, which right now is just outside that door when they reposition it. It was the little ladies in the volunteer shop who bought that first laser, actually, that was ultimately used from, the purchases essentially in that volunteer shop. So this is the device today. As I said, the settings are the same as on that very first case that we treated back in 93. These are just the laser fibers. That's 200 micron laser fibers. So the energy is transmitted through that fiber. You're looking at the stone, it breaks up the stone, and the patient will then pass it after that. So the main problem with this treatment, ureteroscopy, is really not the procedure. I mean, it takes 45 minutes. Everybody goes home the same day, very non-invasive. But we usually have to leave a stent in afterwards. And, just statistically, there's probably at least 20, 30 people here who've had a kidney stone. You don't need to identify yourself. Most of you probably had a stent put in, and they cause misery. These stents are just terrible. So, we've tried to improve things with that, and we did the first study in the world that was designed to not leave routine stents in patients. So this was progress. We could do the procedure, not leave a stent in, and most of the patients we found would do pretty well with that. So I'm going to diverge a little bit here with another story, but don't worry, it's going to connect back to kidney stones. So, we all like to see our kids do better than we do. You'll see here in a minute, I think my kids are well on the way. And they're certainly getting a lot more media attention than I've ever had or deserved. So one of the best things I've ever done is taken the kids as much as I could to meetings, medical meetings. And I always tell people I turn my kids into citizens of the world by hanging out with a bunch of old urologists at medical meetings. So they've been very lucky, I must say, and probably got a better education on these medical trips than maybe they did in school. Anybody recognize that city? Shanghai, that's right. It's very recognizable, of course. We all know where that is. Sydney, yeah. And they've had great cultural experiences. They've had the chance to, learn about other cultures and so forth. This rather opulent hotel here for a period of time last year was a prison in Riyadh, Saudi Arabia. You might know the place I'm talking about. All those folks were put in prison. Anyway, my daughter had the chance to travel with me over to that country and learn a bit about it. So 2 weeks ago, I was walking through Pearson Airport, and I wasn't sure if anybody still read the Reader's Digest, but there it was in the sort of magazine shop in Pearson Airport. And I knew this was coming, so I picked up a couple of copies. And so both of my kids went to veterinary school. They're graduates of the University of Guelph. They fairly recently graduated from Guelph. So the older one is, where is she here? Right there. So the next, Dian Fossey, if you like. So she spends half her time over in Africa and is working with the mountain gorillas to save the mountain gorillas and so forth. And there's been quite a bit of attention with all of this stuff that she's done. And her younger sister, if you've been on CBC in the last 48 hours, was featured on the national news. She's a veterinarian in BC. And where is she here? Down at the bottom. Somebody found a bobcat beside the road, the highway out in British Columbia, and rescued the bobcat. Took it in, she's in the wildlife thing as well. Took in the bobcat. They operate on the bobcat, fix it up, and it's got national media attention. So as I said, I was going to connect this to kidney stones, which I'll now do that. So with both of the kids over in the vet school in Guelph, slowly I get pulled into the veterinary school in Guelph. Teaching, doing research, and stones in animals. And actually in cats and dogs, I didn't know much about this, but now I know a lot about it. Stones are endemic or very common in cats and dogs, people who've had cats and dogs. So here I am now immersed. They've given me an appointment in the veterinary school, and I'm involved in this research. So what we did, cats and dogs are like children, about the same size. We've got all this small technology. We thought if we put a stent in, the same thing I described earlier, maybe we could get a ureteroscope up there and treat the kidney stones in the cats and dogs. So the model was a beagle. And let me just reassure you, when you do animal research in the veterinary school, they are looked after perfectly. There can be no trauma, no sacrificing, we call it. Animal has to survive. So we do all the research, and the beagles are fine afterwards. So we put in the stents. There's an image, CT scan, stents in a beagle. It actually dilated the ureter. So now you can get a ureteroscope up. It's revolutionized the treatment of stones in cats and dogs, and actually won the prize last year at the American Veterinary Meeting for research in the veterinary world. So we'll just finish off here in the last few minutes. We've obviously got a lot of technology for treating kidney stones. It's expensive stuff. All of these things, lithotripsy, lasers, and so forth. So the best thing of all would just be to prevent the kidney stones in the first place, right? We've got rapidly rising incidence, it's doubled in the last 20 years, cost billions of dollars. So the best way to resolve all of this is actually to prevent the stones in the first place, and it's certainly possible to do that. In fact, the best way to prevent kidney stones, and we've got it all right here in the front, good for you, is just plain water. And there are people, and I'm a believer in this, that most kidney stones can be defeated just with plain water as the solution to the problem. So if you are able to increase your fluid intake, so your urine output is 2 to 2.5 liters a day, you're very unlikely to get another kidney stone. So we always encourage the patients to drink lots of fluids. Other things that you can do, salt is a problem, so high sodium diet, a lot of meat, because that's broken down into a compound called uric acid, also is a problem in terms of kidney stones. And we always advise people to increase citrus. So citrate prevents the crystals forming into the kidney stone in the urinary tract. So you can get citrate from lemonade, from lemons. So I always tell the patients 2 liters of water every day, slice up a lemon, put it in that water, and you may never get another kidney stone if you can just follow those very simple instructions. So this is a trial that was done with, it's actually a medication you can take, potassium citrate, that shows a profound decrease in the amount or the number of kidney stones. And I would just finish off by saying the NIH, which is the world's largest funder of medical research, is down in the US. The equivalent here in Canada is the CIHR. Finally, after many years of no funding for kidney stone research, the NIH has caught on. You know, this is a very expensive thing we need to do research for preventing kidney stones, and they're plowing millions of dollars into research on how to prevent kidney stones. But some very practical things actually in the prevention, nothing too fancy. And the first trial actually is a randomized trial using what's called a smart water bottle. So you can buy these water bottles now that will actually link to your cell phone and give you reminders throughout the day of how much water you're drinking. And then the next day, if you haven't had enough water, you get a reminder, you know, you fell below, you know, it's only a liter, and so forth. So smart water bottles are now available for prompting patients, and there's whole behavioral science and everything around all of this as well, all funded by the NIH in the US. So, and again, just emphasizing the importance of fluids, that it will very significantly decrease the chance of another kidney stone. So I'll just finish off there, but let me just say, everything I do here, it depends on a team at this hospital. We've got some great team members I see up in the back here. You know, all of these surgeries we do. I often tell people, Kathy Peach, who's actually up there, has done as many percutaneous stone removals as I have, you know, 3,000. So we're tremendously supported here by the staff at this institution to do the great work that we do. So it's not about one person, it's about the team, and we have a great staff here at this hospital. So I'll finish there. Thank you for your attention.
Good evening. My name is Teresa McCullough, and I'm a very proud board member of St. Joseph's Healthcare Foundation. I'd also like to recognize 2 of my colleagues here today, Keith Trussler and Bill Tucker, who are board members with me. Let me begin by saying how much I really enjoyed this presentation, John. On behalf of everyone here today, you shared some really good insights, and I think we went away with a lot more information than what we knew coming into the room. So thank you. So I think we learned today kidney stones are no joke. If a stone is small enough, it may eventually pass on its own. But if it's large or an irregular shape, it can be excruciating pain. So men here today who have had kidney stones, you know, maybe at the dinner table tomorrow, you can have a discussion with your wife and decide whether passing a kidney stone was more pain than childbirth. We'd love to hear what comes out of that. So luckily, thanks to advancements in medical research, there are many treatments available to us if we ever develop kidney stones. In fact, the urology program at St. Joe's Hospital has one of the most advanced lithotriptics of its kind in North America. I should add that this machine was purchased entirely through donations to St. Joe's. Physicians perform approximately 1,000 procedures each year at St. Joe's, and we just heard it was a very busy day today. Advancing care, finding cures, and easing the burden of disease is what drives the hundreds of clinicians, researchers, and staff here at St. Joe's. But it's really through donations and support that St. Joe's Healthcare Foundation is able to contribute toward research initiatives, specific equipment, and advance in care delivery. As we continue our DocTalks for our second season, we invite you to join us at some of the upcoming lectures to meet some other brilliant minds that are behind the doors of St. Joe's. Please visit the hospital or the foundation website, where you can also subscribe to our email list and receive an update about further DocTalks. We'll be happy to receive an email the moment we open the registration, so you won't miss a chance to sign up. As you can see, this room fills up pretty quickly. Our next Doc Talk is on May 14th with the renowned researcher and physician, Dr. Robert Teasel, who will discuss rehabilitation therapies and technologies that can help an individual recover from a stroke. I guarantee you this will be a very popular topic, so I encourage you to register early. Lastly, I want to thank again our sponsor, CIBC. They have made today's presentation possible. I also want to thank the individuals, the donors who allow St. Joe's to stay at the forefront of medical innovation for the patients and residents that we care for each and every day. Thank you for coming, and have a safe trip home.